Dear viewers, welcome you all to our show Orthopedic Solution Academy. Hope you all are well with your friends, family, and definitely with your patients. Dear viewers, you all know that we discuss about a shoulder topic in our shoulder clinic. And today our topic is very important topic, that is decision making in AC joint separation. We don't know what to do in AC joint separation. So this is a very important topic for all of us. And the speaker is the one and only the GM Jahangir sir, the pioneer shoulder surgeon of Bangladesh. I would like to request Dr. GM Jahangir sir to join with us.
Thank you, Dr. Tanvir Ashraf, for invitation me in the shoulder clinic of Orthopedic Solution event.
Thank you very much, sir, for joining with us. Dear viewers, we have another learned academic expert with us from Bangladesh, and that is Dr. Major General Dr. Anisur Rahman. I would like to request Dr. Anisur Rahman, sir, to join with us.
Thank you very much, Dr. Tanvir Ashraf, allowing me to join these lovely topics. I hope this will help me as well, other viewers. Thank you very much.
Thank you very much, sir, for giving us your precious time. Dear viewers, we have another learned academic expert, that is Dr. Rajeev Raman, sir. Hope he will connect with us in the coming part of our program. Now, I would like to request our honorable speaker, Dr. J.M. Jahangir, sir, to share his presentation. Sir, would you please share your speech, sir?
Dear viewers, very good evening with my dear colleagues, Dr. Tanvir Ashraf and Major General Anis Rahman Halazad sir. I am now presenting a topic of shoulder complex. Among them, AC joint separation is one of the shoulder complex injury, and it is common in our daily activities. So, AC joint separation is about 9% of shoulder girdle injuries. Generally occurs in male age between 20 to 30 years. Up to 40% of shoulder injuries in elite athletes of contact sports. So we now know the surgical anatomy and of the ligaments of AC joint. Fukuda et al. Describe its important surgical anatomy like AC ligament, acromioclavian ligament. It resists about 90% of anteroposterior translation of the AC joint. That is, it is horizontal stabilizer. And next come to the CC ligament, coracoclavicular ligament. You can see this is two coracoclavicular ligament. That is trapezoid and this is conoid. Conoid medially and trapezoid laterally. Trapezoid lateral resists 75% of joint compression, and conoid, which is medial, restrained to the superior translation of the AC joint. So these are the very important ligaments of the AC joint. So Rockwood and classification classify AC joint. There are 6 variety AC joint separation. Among them, first variety, that is only ligamentous stress of the AC, that is acromioclavicular ligament stressing. And type 2 AC separation or AC dislocation, that is complete rupture of the AC ligaments and strain of the coracoclavicular ligament. And type 3, complete rupture of both AC and CC ligament. You can see in this diagrammatic figure, that is type 3, but it is undisplaced. And type 4 variety, that is clavicle displaced posterior over acromion. Posterior over acromion. In normal FEB, we cannot evaluate the type of 4 variety, and we assume that is a normal, but it is a type 4 variety of AC joint dislocation. And type 5, it is displaced superiorly about 2 to 300 times of the diameter of the lateral and of the clavicle. And that is clavicle, that is SIG variety, which is rare, which is displaced up to the subcoracoid region. There is 6 variety of Rockwood classification, also other classification, but usually Rockwood classification is regularly we used for treating the patient. And how the AC joint separation occurs, it may be direct trauma or what the lateral aspect of the shoulder, or fall on the top or lateral aspect of the shoulder. And you can see here this figure, fall on the outstretched hand and also fall on the flexed elbow. All this leads to separation or dislocation of AC joint. When we go for the physical examination of the AC dislocation, usually we find there is lateral end of the clavicle prominent and sometimes tenderness over AC joint, and cross-arm adduction test positive. That means cross-arm adduction test positive, and AC resist extension test positive, and AC compression test positive. And these three tests very important for the diagnosis of the AC dislocation. But when it is in bulky patient, usually we do not see the bulge. And in this situation, only we find out the tenderness as well as the symptom of the patient. So these resistor extension test, compression test, and cross-arm adduction test very important for detection of the AC separation. Usually X-ray, it reveals the AC joint dislocation. Normal anterior view sometimes maybe evaluate the dislocation. And in this situation, we do stage view. Stage view keeping the weight on the affected arm, and then it reveals the dislocation. And very important for assessing the AC separation or AC joint, any problem like arthritis, trauma, can Janka view reveal it. And it is done with FEView with a 10 degrees upward tilt direction. This is the, you can see here, that is Janka view for detection of the AC joint pathology. You can see this is a both side AC separation. Here normal view you can see, and that is separated away from the coracoid. And now decision in the treatment purpose, what will we do for the varieties of AC separation. When it is come to us with type 1, type 2, we treat it conservatively, like rest and analgesic, and after 2 to 6 weeks we send the patient to send the patient to normal activity after the rehabilitation. And this is called sling 2 to 3 weeks, and mobilizes as patient tolerate, and return to work 2 to 6 weeks after the total time of injury or day of injury after 2 to 6 weeks. This is type 1 and 2. When it's type 2, it is a controversial for the type 3 variety, although here all AC ligament and CC ligament torn, but it is some sort of dislocate or subluxated. And this is come to several literature evaluate that when we go for this type surgery, need for maybe second surgery, or there is chance of infection, decreased range of motion of the shoulder joint, and decreased muscle strength. Sometimes it causes pain, and increased return to activity time, except deformity in general procedure. That means when deformity, except deformity, all are in this favor for the type 3 treatment, type 3 AC joint separation treatment. And in this, when we go for type 3 surgical procedure, when patient is young, athletic individual, heavy laborer, and those who overhead work, who do overhead work, all this situation we could do go for type 3 treatment and surgical procedure. So there are varieties of surgical procedure which are done previously, and most of them are now lessly practiced here. You can see here there is K wire passing from the acromion to the clavicle. This is called Femister technique of treating the type 4, 5, 6 of AC joint separation. And this is Bosworth screw. And this is hook plate, the clavicular hook plate, and this is tightrope. Among the Femister technique and Bosworth technique and clavicular, all these implants may be sometimes broken or full out, and causes again dislocation of the AC joint and require the second surgery. And some surgical treatment, now it is arthroscopic and open newer treatment. It may be tightrope. Tightrope in this position, number 5, fiber wire, flat button over the clavicle and oblong button for the coracoid. This is the fiber tightrope treatment of the AC joint separation. And here it is the last, that is ligament augmentation reconstruction system. Last technique, we can see there is a last technique procedure for AC joint separation. And reconstruction of ligament now come to the very recently used this technique, and we also practice this type of technique. And anatomic CC ligament reconstruction, that is Mazakko technique, and anatomic CC ligament reconstruction as well as CA ligament reconstruction, that means posterior superior augmentation of the AC capsule. And this is Fukuda et al. It is now used widely in the over the world for the treating disease separation. Also, autograft semitendinous, gracilis, allograft, single or double banded CC ligament, AC ligament reconstruction, tightrope, use fiber wire, ethicon for the augmentation of the reconstruction. And synthetic ligament like large surgery can be used for reconstruction. Surgical management, which was done initially, that is modified over done procedure, and arthroscopic assisted or open procedure. You can see the literature, that is semitendinous tendon graft versus modified over done procedure for acromioclavicular joint reconstruction in conic cases. Semitendinous graft resulted in significantly superior clinical and radiologic outcome compared to modified Dan Weber. That is arthroscopic assisted or open procedure with ligament may be better than the Dan Weber technique. Reconstruction AC ligament may serve important role in decreasing in situ graft force during the healing, if the literature shows. Now you can see here there is some AC joint separation patient. In this set, it is type 5 variety of. This is also high use variety, and all are leads to 4-5 variety of AC joint patient. AC joint separation, a more patient and X-ray. You can see here this is bilateral AC joint separation, AC joint separation, and AC joint separation. And surgical procedure which are we done usually, that is anatomic CC or CA ligament reconstruction, augmentation with ethibond number 5 or fiber tape number 5. You can see here harvesting the graft semitendinous tendon, and it's measuring about 120 or 130 length, and here we expose the clavicle, lateral end of the clavicle, and excise about 5 to 8 millimeter. Then 2 drill hole is done. A bit lateral one, that is for the coracoid, for the trapezoid part, a bit post superly, and in case of medial, that is conoid part, that is a bit posterior margin, near the posterior margin of the clavicle. And this graft is figure 8 above the deep to the coracoid process, deep figure of 8, and at the superior U loop of the ethibond or fiber tape, and then medial end is transferred to the posterior superior part of the AC joint, that is posterior superior capsule augmentation, that is Fukuda technique. We do it now. This is again, this I have seen this technique we use, that is ligament is figure of 8 technique, and augmentation ethibond or fiber tape is U loop, and one is from anterior to posterior, and 2 through the hole, clavicular hole. You can see this type. And So you can see some postoperative X-ray. That is excision of the lateral 5 millimeter, then 2D, and ligament is figure of it over the clavicle, augmented with ethibond or fiber tape. Again, you can see that a right clavicle dislocation, and it is fixed with anatomic coraco-clavicular ligament reconstruction with hamstring tendon and augmented with ethibond number 5. After the procedure, there are complications of AC joint separation like AC joint arthritis, scapular dyskinesia, sick scapular syndrome, fracture clavicle, fracture coracoid, implant payload infection, shoulder stiffness, rotator cuff problem. There may. So, key take-home points: type 1 and 3 good, excellent result in conservative of majority patient at all level, minimal function deficit if any, relatively rapid return to activity, delayed reconstruction available if symptomatic, and type 3 surgical intervention in overhead athletes, laborious high demand activities, and type 4 and 6 surgical intervention is indicated mostly anatomic coracoclavicular and CA ligament reconstruction augmented with ethibond. And thanks for listening.
Thank you very much, sir, for your excellent presentation. And now I'd like to request our honorable faculty, Major General Raman sir, to share his knowledge regarding the presentation, sir.
Well, thank you very much, Jahangir bhai, for enlightening us a good idea about the AC joint dislocations, its managements, different options, conservative and both surgical. I am fully agreed that what you have said, type 1 and 2 is absolutely conservative. In a sense, the CC ligament is intact in this group, and 4, 5, 6, since AC and CC ligament is disrupted completely, and in case of 4, radiologically, even we do not see by AP view, but if we take axillary view, then it is clearly visible, or in even CT scan, we can see by 3D that yes, there is a posterior displacement. So in that case, it is quite evident that in case of 4, which is not visible in X-ray, but in other position, it is clearly visible, and 4, 5, 6, the surgery is the option. Now the question is, why for surgery? As you know, the AC joint is the one of the very important part playing for the shoulder joint movement. The shoulder joint moves like forward movement, backward movement, upward movement, downward movement, that is protraction, retraction, superior inferior movement. So these are the movements where the AC joints takes very important role. If we even want to protect too much, the AC joint gives a protection. It limits the protection. Similarly, if we want to retract back, AC joint also protects, cannot. Similarly, upward and downward. So as such, we need to have a very good AC joint stability. Now, the options of surgical treatment, there are a lot of options starting from hook plate and to up to the hamstring support along with internal brace. As the AC joint, the stability comes by the main is the AC ligament, acromioclavicular ligament. As you say, I do also agree that is 90% stability comes from AC joint, and the other part is given by the CC ligament. So if we repair both AC and CC, that is the biological support having the full movement, and full stability. So as such, for AC joint stability, there are a lot of options, starting from hamstring by one, giving the support of CC and AC by figure of 8, or even some authors in the literatures that the acromio, that is coracoacromial ligament, even separating from the uh, acromial process, putting inside the distal part of the or lateral part of the clavicle, and giving our reconstruction of the CC joint. That is also the many out of many options. This is one option. The another important issue is we must, what I believe, if the distal lateral part of the clavicle remains intact, once it is separated, after whatever reconstruction it is being made, but it remains little bit of unstable and makes the issue of permanent pain. As such, excision of the lateral part, either 2 to 1.5 to 2 centimeter lateral part, and the issue of the arthritic AC joint and reducing the pain is very much helpful, as and we are practicing regularly now these options. We are also in our setup, since we are having all young patients, high demanding, need to participate very early. As such, from group 3, 4, from group 3 to 6, we all go for surgical treatment, and we exercise the lateral part of the clavicle. We fix by with the hamstring tendon semi-T. Then we also put a internal press like type 2, which the aspects they have got, like the flexible one, which length is almost 60 millimeters. That gives a big support. What we are using in the AC ligament reconstruction, just for a moment. Am I audible, sir?
Yes, sir. Yes, sir.
Okay.
Yes, sir.
So by the type 2, which length is 60 millimeters, yeah, 50 to 60. AC ligament reconstruction by open loop. So that is very much helpful. If you put it and hook it, that is very easy, not to put so many drill. If you make a drill only on the clavicle and just rotate loop, make a loop under the hook of the coracoid process, that acts as internal brace, and then with the hamstring make a figure of 8. That I believe very good support. We are regularly practicing these issues. Regarding the hook plate, it's difficult. Sometimes it's broken. An issue of removal is also there. Patient psychology, younger patient, they have always psychology. Oh, doctor, when you are putting this, when you are taking this out, and pain is one also another issue. So I am sharing my hospital practice, and I also want to know your practice and your result. Rajeev Raman is there. He can also join us. Thank you very much.
Thank you very much, sir, for sharing your great knowledge with us. Sir, I have one question to you, sir. You told that in case of type 1 and type 2, you go for conservative treatment. As because of the AC joint separation operation is relatively rare in our country, not all the surgeons are doing that operations. So they all try to do conservative treatment. Do you have any protocol of conservative treatment? As because of sometimes we use elbow bag, sometimes we use leukoplast strapping there, uh, many other things we are doing. Is there anything systematic way that we can treat the patient conservatively? Do you have any suggestions, sir?
Wait. Thank you very much.
Sir,
Um,
my question is to Dr. G.M. Jahangir, sir.
okay.
Thank you, Dr. Ashraf. So type 1 and type 2 AC joint separation, usually we go for conservative management. If you immobilize it for to 1 to 2 weeks, not more than 2 weeks, immobilize only. Then range of motion shoulder exercise, ROM exercise should be done, started immediately after removal of elbow pouch or elbow sling. And then it is continue after 3 to 4 weeks, you give the strengthening exercise. Strengthening exercise, then allow the patient. If the patient is sedentary one, if patient is OP job, no problem. If it is active patient, if he do playing another contact sports or she heavy laborer, depending on his profession, it should be delayed, as because there is both 1 to type ligament. In case of type 2, that is complete AC ligament tear and sprain of the CC ligament, and horizontal stabilizer is AC ligament. So you should delay his activity like pushing, lifting, and overhead activity. It should be delayed up to 12 weeks. This is the protocol for that means 1 to 2 weeks rest or immobilization, then range of motion up to 6 weeks, and after 6 weeks muscle strengthening exercise of the shoulder. If patient is active one or sporty contact sports overhead activity, then you go for after 12 weeks, then his patient is allowed to go to his normal activity as he before done.
Thank you very much, sir. Anisa, do you want to add something regarding the question, sir?
Exactly. We also practice 2 weeks on sling, then another 2 weeks nothing doing. Just he will do his normal activity, not any military activity. He will do his normal day-to-day activities. Another 2 weeks. That will allow him minimum range of movement. Then after 4 weeks, then we send him to physiotherapy to take little bit of further movement. So at the end of 6 weeks, he have got some movement. Then from 6 weeks to another 6 weeks, little movement, more, but not participating the activities that may hamper his healing. So as such, at the end of 3 months, we allow him to go back to his duties. Thank you very much.
Sir, previously we have seen that many of our doctors in the past time, they use leukoplast for strapping the AC joint. Do you suggest that for doing these things?
Who
Uh,
will give answer?
Sir,
well,
both of you, sir.
Yes.
putting for 1 or 2, hardly there is any disruption or the displacement of the either the clavicle or whatever. So there is no displacement. I believe what we do, putting the sling is just a psychological pressure not to take any load. So if someone even is quite conscious, many patients are, they are quite conscious, they are also educated, they know everything other than the medical knowledge, though not doctor. So if anybody say us that, okay doctor, you don't do anything, what you require, you just tell me, I will abide by. Many of the educated patients, they tell, okay, you want me like this, I'll do that. So even sometimes I do not put even in noticing what about the plaster, what about the leukoplaster, whatever the thing. So thing is that type 1, 2, since there is no displacement, we want no further movement. Either if patient can do it by himself without putting anything, or if some patient, well, his ceiling is good enough. Even if somebody, instead of putting ceiling, if he does apply this leukoplast, all the same.
Thank you.
Thank
Thank
you
you
very
very
much.
much, sir. Sir, GM Jahangir, sir, do you want to add something with this answer?
Yes, actually there is a adhesive stepping regarding the ligament healing or reduction of the AC joint. There is no rule. Only this stepping who apply, it reduces some sort of pain, reduce it is some bit of muscle spasm, muscle spasm. So people so that they have reduced pain after application of stepping leukoplast or any other stepping procedure. That is psychologically effect for it. Actually, we are now doing that is reconstruction of anatomic ligament, and among them, CC ligament is very important one, because this is the ligament of the shoulder complex which transmit the upper limb weight to the axial skeleton. This is the only ligament communicate to the axial skeleton. This is why we are now very concerned about the AC ligament separation to recon the CC ligament. We are very concerned. As because there is Femistar technique or clavicular hook plate or Bosworth screw, all are maybe broken, or when it is removed, there are again redislocation of the AC joint. So these are the not a good enough procedure for recently. This is why anatomic reconstruction is very important. There is no metal, no wire is used in this procedure. What are we practicing? Like our sir.
Sir, sometimes do you use any endo button there to pull down the clavicle?
Yes, when it is compression acute tear within 2 weeks, then you can reduce the clavicle with button. And there is, if you see after doing MRI, ligaments are not separated. Just augment this button reduction is the augment to the ligament, and ligament will heal. And as because this ligament is permanently in situ, sorry, button or tight rope permanently sit there and no removal, so it will help. But when it is chronic cases, when it is more than 3 weeks, but I think ligament reconstruction should be done, because only augment procedure like button will not anatomic one. It may lead to arthritis, lateral AC joint arthritis, as maybe fracture of the clavicle, coracoid as well as clavicle. So I think ligament and augment is a good option for the AC separation.
Thank you very much, sir. Thank you. Yes, sir, please.
I also do agree fully. Look, AC joint disruption mechanism starts from its AC ligament. Once AC ligament is completely ruptured, then it goes on CC ligament. So CC ligament ruptured means AC ligament gone. So only if you go for AC ligament by whatever means, screw, endo button, and the tendon, whatever. But if you don't repair AC ligament lateral part, then it will not work. So what is the easy way? What I do practice after excision of the lateral part, I put 1 or 2 K wire, mostly one K wire, keeping the proper alignment in the lateral part, and seeing the distance of the CC, that is coracoid process, and the clavicle, which is almost sometimes 10 plus minus millimeter. And if it is almost normal, then we put endo button, which acts as also internal brace, endo button, whatever. You can use endo button, you can use tight rope, you can use now recently Arthroscopy they has got a knot that is knotless suture, that also you can use. So whatever you put internal brace, then you fix the AC joint with the ligament and have biological reconstruction of the AC joint with the tendons. Thank you very much.
Thank you very much, sir. Thank you, Dr. G.M. Jahangir, sir, and thank you, Major General Dr. Mahmoud Raman Hawladar, sir, for sharing your knowledge with us. And I would like to thank Raj Tv and Malleus Specialized Hospital for sponsoring our program. Dear viewers, I hope we will connect with you in the coming Friday with another shoulder topic. Till then, I'm Dr. Mahmoud Tanvir Ashraf saying bye-bye to all of you. Bye-bye.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.